when deciding between neoadjuvant and adjuvant therapy, there are several factors one could consider. Some of them are practical, some of them are biological. So on the practical side, with neoadjuvant studies, one can use endpoints that are focused on efficacy endpoints at the time of resection. So for example, one of the popular efficacy endpoints in neoadjuvant studies so far has been major pathologic response. Now, pathologic response as an endpoint is something that is pretty standard in breast cancer. In lung cancer, we really haven't used that as an endpoint, and that's partly because pathologic, complete path response are quite uncommon in lung cancer. And so that's led to this major pathologic response, which is less than 10% of viable tumor cells. So you can design a study where patients get between 2 and 4 doses of checkpoint inhibitor, and then they go to resection. And if with a primary endpoint of major pathologic response rate, you're going to get that efficacy endpoint much sooner than, say, in the adjuvant setting, where you're having patients undergo surgery and you're administering adjuvant checkpoint inhibitor, and you're waiting for relapses as the endpoint. That can take much longer. So that's one of the practical considerations. Another practical consideration is the biomarker question. So for example, there's intense interest in trying to understand biomarkers of response to checkpoint inhibitors. And one of the key kind of avenues to understanding those mechanisms is tissue. Actually having tissue from the cancer and seeing, are there specific genomic markers, the immune microenvironment, are those predictors? And so a neoadjuvant approach actually allows you to have both a pre-treatment set of tissue as well as a post-treatment to see how the tumor has changed in response to your therapy. So I think that's one of the other reasons why there's been some enthusiasm for the neoadjuvant approach, because it allows investigators to actually get more tissue.